And now we'll be introducing our Emerging Leaders Award in Nutrition winner, and that is Laura Chiavaroli from the University of Toronto. So, Laura.
Thank you. It's an honor to follow Byron, who keeps us safe. Thank you. And come a little bit back more to our kind of clinical translation and really helping to kind of, I guess, talk a little bit about high quality science, which I think we talked about a lot this earlier today as well, and really helping to support credible decision making. So these are my disclosures. To try to help with mitigating any potential bias, we work with really large interdisciplinary teams. We have advisory committees of healthcare providers, patient partners, and everyone is involved from inception and throughout. So really helping to have a diversity of opinions and perspectives involved throughout the research. So the two main focuses that I'll be talking about today focus on two areas of my work. One is trying to help with using methodological considerations to disentangle discordant findings and drive high quality evidence to support clinical practice guidelines, as well as nutrition policy updates and modernization. And then the second one is to demonstrate how effective and inclusive interventions can be designed to translate our therapeutic dietary patterns into practice. So we'll start by thinking about the impacts that discordant findings can have. So if you think about the way the public really digests nutrition information, most of it is really contrasting. There's a lot of debate going on, and it can lead to a lot of confusion, which can also kind of trickle into a little bit of distrust in the scientific evidence and the scientific community. So there's a real need to disentangle discrepancies, and that can not only help to drive guidelines, our clinical practice guidelines, but also to help support public uptake of evidence-based dietary advice. So one area of research that I helped with leading was really helping to disentangle the public messages around carbohydrates, and particularly sugar, as the dominant public health concern that was driving a lot of our non-communicable chronic diseases like obesity, diabetes, and cardiovascular disease. So we conducted a series of systematic reviews and meta-analyses, both of randomized controlled trials as well as of prospective observational studies, again, trying to help pool together all that we know and getting at the highest quality evidence. So the research question, which we wanted to focus on, was looking at what the effect of sugars is on cardiometabolic risk factors and cardiometabolic outcomes. And in designing the research question, we integrated both the role of energy, or comparator a lot of time, the role of the food source or the food matrix, and then using the GRADE approach, which is an approach to assess the certainty of evidence, which includes both linear and nonlinear dose response analyses, which are particularly important when it comes to nutrition. So this is just a map of all the different meta-analyses that we did, looking at the evidence on randomized controlled trials across cardiometabolic risk factors, from body weight all the way to inflammation. So this table here presents the overall results of the series of systematic reviews and meta-analyses on randomized controlled trials. Each row represents one analysis that was done for each of the risk factors, and then each column is the way we stratify the studies to disentangle energy. So substitution, for example, is where the intervention and control is being given equitably in terms of being isocaloric, versus an addition study where the intervention is given as advice on top of the diet, which would be given as excess calories. And subtraction is the opposite, where it's being given as advice to remove energy. Think of sugar-sweetened beverage study, where the intervention is then a low-calorie sweetener like a diet pop or water. And then ad libitum is where the prescription is just being given as diet advice. And then you can kind of see how the results of these studies might differ. So you pulling them together doesn't quite make sense, but that's not always the way that data is analyzed. So looking firstly at where we saw breaking down the evidence by food source or food matrix, on the slide you can see all the different food sources that we looked at. So sugar-sweetened beverages, fruit drinks, etc., teasing that apart. So where you see harm is predominantly coming from studies where they're looking at sugar-sweetened beverages as the intervention, and it's predominantly in the addition studies. So when it's being given or prescribed as a source of excess energy. And in these studies, you're roughly seeing at about 20 to 25% energy coming in these interventions. There's also a signal of harm in what we call mixed studies. So there was always a sugar-sweetened beverage paired with another food source of sugar. Interestingly, when we looked at other food sources, you see things like fruit, for example, showing benefit, and 100% fruit juice, which is something that's always kind of, is it or is it not something we should or shouldn't be eating or consuming? And then there are a couple other food sources as well. And in these cases, they're kind of falling both in the substitution and addition studies, because when it's being given, there are the other kind of effects that can happen with these kinds of foods, like satiation, which then, even though you're being prescribed, let's say, 2 apples a day, it ends up displacing other things in the diet. This is the map of the reviews that we did looking at cohort studies in the meta-analyses across the cardiometabolic outcomes, looking at incidence of diabetes to cardiovascular disease. And I've presented the results here as a heat map. So across the top, when you see the rows, you're seeing the meta-analyses on the different cardiometabolic outcomes. And then the rows on the side are showing you the results for each of the individual food sources. The red indicates where we see harm, and green is where you're seeing benefits. You're seeing a reduced incidence, and the intensity of the color is telling you the intensity of the magnitude, so higher magnitude. And so similar to what we see with the randomized control trials, when you're looking at where we see harm, it's predominantly a signal that's being driven by sugar-sweetened beverages. As well, here we're seeing fruit drinks and mixed fruit drinks and confectionery. And then conversely, when you're looking at the evidence on food sources coming from fruit, 100% fruit juice, similar to the RCTs, we're seeing benefit. And then in the cohorts, we have the evidence to demonstrate whole grain breakfast cereals, yogurts, and even ice cream and chocolate can see some positive effects. To dig into a little further and show you some examples of the importance of dose, this is just presenting the data a little bit differently. So you've got the prospective cohort studies of meta-analyses looking at the various outcomes by rows, and here we're just looking at it overall by sugar. And so where we see some of those signals for harm, when you look at the dose response analysis, you're seeing that there's kind of this U or J-shaped type curve where you're really only seeing the harm start to happen when you're consuming the sugar at over 20% energy. So again, it's very similar to what we're seeing with randomized controlled trials, that when these foods are being consumed as a source of excess calories, that's when you're seeing the signal of harm when it comes to health. And then just one more example to show dose response, again, getting at fruit juice, because this is still something we talk about a lot. When you do the nonlinear dose response, and you can see how it contrasts to the evidence on sugar-sweetened beverages, which is very linear. With the fruit juice, we're seeing a U-shaped curve where you're actually seeing a reduction in the incidence. In this case here, it's metabolic syndrome incidence, and you're seeing a reduction in metabolic syndrome incidence when you're having about half a cup or 125 ml of 100% fruit juice. And it's a similar signal that we see for hypertension incidence. Okay, so this is a slide just to kind of show a little bit about the influence that these meta-analyses have had. They've been used to help shape the updates of clinical practice guidelines, as well as other policy documents, including ones that are driving health claims, position statements on sugars, and dietary guidelines on sugars. And the importance of these methodological considerations and disentangling these differences that you see by food source is also reflected when you look at the shift in our dietary patterns, which about 10 years ago were really more focused on nutrient-based, but since then we've been really shifting more toward a food-centric approach and more so broadly dietary patterns. And that's where we're gonna kind of get into a little bit more. So I did a series of systematic reviews and meta-analyses looking at the effect of dietary patterns on cardiometabolic risk. And these were commissioned by the Diabetes Nutrition Study Group as a means to help with the update of the European Association for the Study of Diabetes Clinical Practice Guidelines for Nutrition Therapy. So these are the three analyses that were done. I looked at the DASH diet, or the Dietary Approaches to Stop Hypertension diet, which targets blood pressure, low glycemic index diets, which is predominantly to help with blood sugar control, and then the portfolio diet, which is predominantly to help with cholesterol or LDL cholesterol. So these have all been exceptionally well cited and really helped to drive a lot of various clinical practice guidelines internationally. I'll just show you a couple slides to show you what the results were and really why they really helped to move things forward a little bit more. So this is the slide that's showing the results of the meta-analysis done on the DASH diet. Here we've got kind of a plot that's demonstrating the effect on each of the individual cardiometabolic risk factors that we looked at. So even though the DASH diet predominantly is designed to target blood pressure, you're seeing that nice clinically meaningful reduction of over 5 millimeter of mercury reduction in systolic blood pressure, but you're also seeing reductions across cardiometabolic risk factors, including your lipid targets and some glycemic control and body weight as well. Similarly, the meta-analysis that was done on low glycemic index diets, so when you're choosing carbohydrate foods that result in a blunted glycemic response compared to diets of higher glycemic index foods, you are seeing that clinically meaningful reduction in hemoglobin A1C as your measure of glycemic control. But then again, very similar, you're seeing the reductions and benefit across various cardiometabolic risk factors. And then lastly, the portfolio diet. Again, that nice big reduction in LDL cholesterol, but then again, you're seeing reductions across other risk factors like blood pressure, inflammation, and estimated coronary heart disease risk. So these kind of collectively show you the impact that a dietary pattern can have, not just on one risk factor, but on a multitude of risk factors. And these systematic reviews and meta-analyses of these dietary patterns have influenced clinical practice guidelines for heart health, diabetes, obesity, both nationally and internationally, as well as public health dietary guidelines. So moving on to the second objective, which is really the heart of my current research focus, it's really helping to understand what approaches we can take to really help now take all this knowledge that we have and take those clinical practice guidelines and put them into practice in the real world. So there's a variety of dietary patterns, of therapeutic dietary patterns that are recommended in clinical practice guidelines: vegetarian, DASH, Mediterranean, portfolio, low GI. But then again, when we think about what the public is kind of consuming in terms of dietary advice, it's very rarely that they're hearing about these evidence-based dietary patterns. They're hearing a lot of what they see maybe in books that are coming out, or more likely on social media and online, which are many times not scientifically sound. Okay, so my lab has really started to focus in the past few years on helping to develop translational tools to really help with getting the guidelines out of paper and into practice. So when we were thinking about how we would design these, we started to think about broad accessibility. And with the uptake of digital technology, especially post-COVID, we wanted to first understand whether or not that could be a platform for us to use. And there is, there's a lot of evidence out there that mobile health apps and other type of digital technology can really help. This is just a meta-analysis that demonstrated that web-based apps can really help with driving down LDL cholesterol, for example, as well as other cardiovascular risk factors. So we thought, all right, we're going to start with getting into the digital space. So having that understood, we wanted to be able to show how health apps can help with education and engagement of patients to increase the uptake of dietary patterns for chronic disease prevention and management, and as a platform for us to be integrating strategies to help with sustained behavior change and supporting that patient-provider relationship, and then again, allowing for that broad accessibility. When it comes to diet, adherence really is key. A lot of diets can work, but really people need to follow it in order for it to work. So that is the kind of first point that we always kind of reflect on how we can support. And then beyond that is the sustainability of it. So not being something that you just try for a little while and then go back to your normal ways after that, but something that becomes a new lifestyle habit. So with that in mind, we integrate and work very closely with experts in behavior change theory, as well as integrating co-design frameworks to really build sustainable interventions. So I'm not going to go into behavior change theory too much, but just generally, one of the most common theories is the COM-B model. And the background of this is that in order for people to change, they need to have the capacity, they need to be motivated, and they need to have opportunity. So the COM-B model can be mapped to theoretical domains, and these I'm not going to go through, but there's science and there's evidence behind the way in which we can design interventions to really help with driving sustained change. A lot of these things you'll be familiar with: building knowledge, testing your skills, goal setting, thinking about the beliefs of capabilities, and then thinking about how you can navigate social influences in situations. When it comes to the co-design theory, again, I'm not going to go into it too much, but generally speaking, what we do is we bring everybody to the table. All interest holders are at the table at the beginning when we design these, to ensure that we're bringing all those perspectives together, making everyone feel valued to be able to share in creating this prototype of the way in which we want to try to translate information. And with that, it really helps with designing things that can be implemented in the future that will fit within the health services or in community settings. So the first dietary pattern that we focused on beginning to translate is the portfolio diet. So for those who are unfamiliar with the portfolio diet, it is a portfolio of cholesterol-lowering foods, each of which carry a health claim for cholesterol or coronary heart disease risk reduction in Canada, the US, and or Europe. And it consists of nuts and seeds, plant protein, predominantly coming from soy or dietary pulses, viscous fiber, that sticky fiber that's in your oats, plant sterols, and monounsaturated fatty acids. So there were two areas that we started with translating the portfolio diet. First, our healthcare provider-facing toolkit. A lot of physicians don't get a lot of nutrition education, so it's really hard for them to take the guidelines and even talk about it to a patient if they're not familiar with it. So we created an infographic and video to help with relaying that in less than 5 minutes. And then we have our portfolio diet program. Really helps with that sustained learning and dietary change. This is what our final healthcare provider-facing portfolio diet infographic looks like. This is my PhD student, Gabrielle Viscardi, who led this work. So we've recently validated this in 60 diverse healthcare providers, and with the study, we demonstrated that they do indicate an increase in their knowledge and confidence in recommending the portfolio diet and the portfolio diet app, which I'll get into shortly, to their patients, as well as increasing their confidence in being able to recommend the toolkit to other clinicians. And this is currently under review. So we started in the translation of the portfolio diet with a portfolio diet infographic, which does provide the QR code for patients to then access the app, which is the foundation for the entire program. And we work with the Canadian Cardiovascular Society, again, thinking about how we can build credible tools that'll really be something that physicians and healthcare providers can help with translating and is freely available for patients to access. So this is the CCS website where you can see the infographic that helps with making it something that is a credible source of information. So the portfolio diet program, I'll briefly just kind of review for you to give you a sense of what it is. So the basis of it is a mobile health app. There's then a Kickstart package, which is a daily email that comes in to help with onboarding patients with information. It's a little video and then some resources to slowly help pull out a lot of the resources that we have within the app to help them learn. We also have text messages to help, so a lot of people download an app and then never use it again. So this way it is a nice gentle reminder of the steps that they're trying to take toward improving their health, and then it links them back to resources and other aspects within the program. And then we have a 16-session online behavioral program, which helps again with engaging them with a variety of the content. And this is all developed with the integration of behavior change theory. We have our behavior change theory expert, Dr. Michael Vallis, who's a psychologist at Dalhousie University, as well as Diana Sherifali, who is an implementation scientist and really helps with health services research to ensure that whatever we're designing here is really going to be something that can be taken up later. And they're both on Diabetes Canada clinical practice guidelines, so ensuring that it can align with something that can be taken up in the future in guidelines. And then we have our health organization partners and our community. So a couple of the features of the Portfolio Diet program, these are the key features that are highlighted within the app. Again, as I mentioned, all of them are mapped to behavior change theory to really help with encouraging and engaging people with the content. On the dashboard of the Portfolio Diet app, it's not meant to be a diet record, it's just something to help them track the consumption of Portfolio Diet foods. So similar to what we were hearing earlier about that, trying to make people feel about positive food choices. So the target here, there's a little bullseye, and if you click on it, the target is a score of 12 out of 25. So we created it to be point-based as opposed to serving, so they can think about it kind of a little bit more fun. There's a lot of evidence that gamification works with engaging people. So, and this is evidence-based in the multi-center trials that have been done on the Portfolio Diet in the past. With diet advice, about 50% adherence is what you get in the real world, and that still results in a clinically meaningful reduction in LDL cholesterol of about 10 to 15%. So by aiming for something that's feasible and achievable, it can really help with engaging people to feel like it's something that they can do. Again, on gamification, there are a couple other things that we have in there. An example is a quiz question of the week to test their skill building and their knowledge of the diet. And then if they get the question incorrect, it'll help guide them to more information to learn about that aspect. They can track their changes in their clinical measures. So if they're interested in their LDL cholesterol or blood pressure, they can track it and it'll graph it with their Portfolio Diet score. And there's a print button so they can share it with their healthcare provider if they like to help with that patient-physician relationship. There's a wealth of online resources available to participants. There's tip sheets that not only help with engaging them and learning about the different pillars, but also other things like allergies or budgeting, if budget is a consideration, as well as how to help navigate things like fiber and bloating, because if you jump into fiber really quick, you are going to feel it. So it's, again, trying to help with people learning about those type of transitions to their diet. And then we have a lot of engaging videos as well. We work with a culinary institute, George Brown College, to help with really creating a lot of cultural diversity in the recipes. I'm just going to blaze through these a little bit because I only have 5 minutes left. We have our curriculum where it really helps with things beyond just education on the portfolio, but things like problem solving. So using examples of challenges that you might encounter when you're making a dietary change and how you can use problem solving to get at that. And we use interactive modules online to be able to do the curriculum. So there's learning objectives to keep it focused, and then there's fun activities, knowledge checks, and then reflection pieces and goal setting to help guide them along the way. Adherence, again, I mentioned earlier, is really key, and that's something that's reflected in guidelines as well. So as we're now getting into testing our program, we work with high-risk communities. So the Peel region of Ontario is an example that has an extremely high concentration of self-identified ethnic minorities, and it does have the highest prevalence of type 2 diabetes above the provincial average. So we work with the community to use the program and then provide us with feedback. So in the assessment that we did recently, we demonstrated there was a significant increase in knowledge of the Portfolio Diet, good usability of the app. There was a need for a few more culturally relevant recipes, so we identified the different cultures that we needed to work with. We also did some subgroup analyses to demonstrate that everyone is finding the program equally usable. And then we have 3 clinical trials that are going on right now. They're all launching in the next 3 to 6 months to assess the implementation of the Portfolio Diet program in different settings. So I don't have time to go through all of them, but just to give you a quick view of them. One trial we have is called the CHEAP trial, which is the coronary heart effectiveness assessment of the Portfolio Diet in primary care. So this is a CIHR-funded study that is demonstrating how the Portfolio Diet program can work as it would in the real world in primary care. So this will recruit 1,100 high-risk adults who will either be randomized to the Portfolio Diet program or just to continue standard of care, where the goal is to demonstrate a clinically meaningful reduction in LDL cholesterol at 1 year, and then to move on to 7 years to demonstrate a reduction in major adverse cardiovascular events. The next trial we have is the SWITCH trial, and this is the substitution of high with low ultra-processed soy protein foods in a guideline-based diet intervention for cardiometabolic health. Those are the wonderful graduate students that are working on this. This trial was designed to have 2 research questions. What we did with the portfolio diet program here is want to take it a step further and try to leverage other dietary patterns. So we know that the portfolio diet can result in a reduction in systolic blood pressure, but it's about 1.75 millimeters of mercury. So we wanted to enhance that by combining one of the key elements of the DASH diet, which is recommending fruits and vegetables, which wasn't a key feature of the portfolio diet previously. So the question is, does a DASH enhanced portfolio diet lead to meaningful reductions in systolic blood pressure as well as other cardiometabolic risk factors in 300 individuals with hypertension and obesity, 50% of whom will have type 2 diabetes. And this is a 3-month trial. And then the second question that's added in here is that because it's a 3-arm trial, participants are randomized to either standard of care or to one of 2 DASH enhanced portfolio diets. So this design of this study allows for superiority testing to see whether or not the DASH enhanced portfolio diet works on top of standard of care. And then with the non-inferiority design, we can assess that the high versus low UPF soy protein foods are non-inferior. So it's demonstrating whether or not high UPF soy protein foods can fit within a guidelines-based diet. The last study is a diabetes remission study called the REPAIR trial, and this is a 52-week randomized control trial that's looking at whether or not a plant-based intensive lifestyle intervention can help with diabetes remission. And then just to highlight an upcoming piece of work that we're working on is translating the glycemic index. So this is something in partnership with Diabetes Action Canada, Diabetes Canada. We have a certified diabetes educator community and patient partners. We have community partnership to represent high-risk communities. And then we have our decision makers and interdisciplinary team guiding this work. So we have a prototype of the app that's starting, and we are currently undergoing some interest holder meetings to truly help with making sure that the way this is designed is something that's going to meet the needs of the user. And then just a couple of fun things we have going on to, again, help with that opportunity piece. So when you go to the grocery store, how do you know whether or not a food aligns with the dietary pattern? We are creating nutrient profile models and then working with our collaborator at the University of Toronto, Dr. Mary Lebay, who has one of the largest grocery store food databases in Canada, so that we can have barcode scanning features in the apps to help with identifying foods at point of purchase. In conclusion, hopefully I've helped to demonstrate that there really is an importance in integrating the role of energy or the comparator, the food matrix, and dose within research questions to really help with entangling discordant findings that can really help with driving guidelines and uptake for that consistent and clear message. And that, the approach that we're taking to really help with designing translational tools is something that integrates both co-design frameworks, behavior change theory, and digital technology to really help with supporting adherence and sustained behavior change with really broad reach, and in partnership with Canadian Cardiovascular Society and Diabetes Canada, making these things something that are freely available and credible. Okay, and if you want, both apps are freely available, so you can take a look. And with that, I'd like to thank my lab and all the hard work that they do in putting all of this together, my funding sources, and there's the QR code if you'd like to take a look. Thank you.